Can you see my screen كده يا صافي؟
ايوه يس.
Okay. طيب I'm ready when you are ready يا دكتور صافي.
طيب، بسم الله الرحمن الرحيم. صلاتي وتسليمي على خير خلقه محمد المعروف فينا بصدقه، وعلى آله وعلى عشقه صلاة تدوم ما دام طير بأفقه. Uh, Today I would like to welcome all the الحضور الكريم في ISAP for today's session. واليوم هو يوم النفرولوجيست. نرحب بالدكتورة نهلة علام from نورو سنتر اوف بيدياتريك كدني ديسيز اند ترانسبلانت. وكذلك نرحب بالدكتور دكتور ياسر محجوب from كينج سلمان تبوك. He's also consultant pediatric nephrologist. He did his fellowship in Cape Town, South Africa. ونرحب ببروفيسور ساتي وهو غني عن التعريف. نرحب بدكتور كريم وحاتم محمد احمد صديق، وهو حيكون على الكيو ان اي. وما ننسى نشكر كثير جدا دكتور عبد الهادي عبد الجبار، وهو يعني يعمل من خلف الكواليس لإنجاح هذه السيشنز، وهو طبعا صاحب الفكرة اللي ما شاء الله مشت على خطى لأن صارت آيساب. نشكر كل من ساهم في إنجاحها، ونرحب بكل الحضور. Our speaker today is Dr. Mohamed Abdin Karar. Dr. Mohamed, he's graduated in University of Medical Science and Technology. He did his MD in Pediatric 2017 and his fellowship in Saudi Arabia. Now he's working in Military Hospital Riyadh, and currently he's the General Secretary of SAB KSA. وأختم بأنه يعني نشكر دكتور طه إبراهيم يوسف، وطبعا كان في السعودية هنا وما زال في الجروب حق ساب كي اس اي. نرحب به في انه عاد. المفروض نودعه انه طلع من السعودية رجع لبلده يعني ايرلندا. ونرحب بالحضور الكريم. وانا عاوز ارجع لانه ابدا بالقرآن الكريم. أعوذ بالله من الشيطان الرجيم. إذا جاء نصر الله والفتح ورأيت الناس
أنا كيفك؟
يدخلون في دين الله أفواجا
القرآن. الله
فسبح
عليكم
بحمد
عزانا يا أخي.
إنه كان توابا. تفضل دكتور محمد. صدق الله العظيم.
صدق الله العظيم. شكرا جزيلا دكتور الصافي. Welcome everyone. This is me, Mohamed Zain Abdin Abdurrahim Karar. I'm a pediatric nephrologist from Prince Sultan Military Medical City, and today I will be talking to you about pediatric urolithiasis presentation and management. I just want to welcome Dr. Nahla, who is our teacher, and Dr. Yasir, who is also our teacher from previous relationship and knowledge in Sudan, working with them in Noura Center for Kidney Disease and Transplantation in Soba University Hospital. Dr. Nahla currently is in Oman, Muscat, and Dr. Yasir here is in Tabuk. I'm very thankful for them to join us for this presentation to share their expertise also and comments on pediatric urolithiasis. So the outline of this presentation will be, we'll start with history and epidemiology of stone disease, definition, pathophysiology, Randall plaque, clinical presentation of kidney stones, stone analysis and causes in children, treatment, medical treatment and urological treatment. And then we will discuss situation in Sudan with our panel. So we start with the history. In 1901, the English archaeologist Elliot Smith discovered a stone in the pelvis of a mummy from Egyptian tomb. C14 isotope studies helped dating the mummy to 4,800 قبل الميلاد. Since then, paleopathology, علم الأحياء القديمة, has revealed many other prehistoric and unsigned cases of stone disease in various continents of the globe. Renal stone from paleopathology, علم الأحياء القديمة, has identified different stones in Europe, Africa, and America, and most likely, although not documented, in Asia as well. Interestingly, as you can see, it has been seen in Jebel Moya in Sudan that 1100 قبل الميلاد, multiple several individuals has been actually diagnosed with bladder stones, and they complained of bladder stones at that time. Perinatal lithotomy. Shuhruta is one of the Indian surgeons, and it has been named as father of surgery. 600 قبل الميلاد, this Indian surgeon has invented what's known as perineal lithotomy. And he documented the procedure of perineal lithotomy in his book, Shuhruta Samitha, and his book translated in Arabic and English. Shuhruta statue is present in Australia in the Royal College of Surgeons in Melbourne and Australia. It has contributed immensely at that time to the kidney stones, bladder stones, and how to remove them. Since Shuhruta at 1000 year, Abu al-Qasim Khalaf ibn Abbas al-Zahrawi, who is known as Abu al-Qasis in English, he was in Al-Andalus, and he took the work of Shuhruta forward, and he described how exactly perineal lithotomy will be done. He also wrote a 30-volume encyclopedia of medical information called كتاب التصريف لمن عجز عن التأليف. Abu al-Qasim al-Zahrawi is considered as one of the contributors of improvement on modern kidney stones and urinary bladder stones removal. He revolutionized the procedure of perineal lithotomy, and he invented what's known as al-kalalib, which is a crushing forceps. And he also invented al-mish'ab, which is a driller fragment forceps. And he had a lot of contributions in medicine other than this. But when it comes to the stones, he is known figure in this field. Since that time, people have updated the instruments. They try to come with a better one, but the procedure in general has been coming from the history of these doctors. We come to epidemiology of urolithiasis. When we come to talk about the epidemiology, we talk about what's known as the Asian African belt and the American belt. And this belt, as you see, it transverses the globe. And this belt is directly related to ambient temperature. It is estimated that 10 to 15% of kidney stones and 12 to 15% of kidney stones are in these belts. Also, Europe, compared to these belts, have lower kidney stones. But with the climate change, you might see this percentage are different now. And this is more detailed picture of how ambient temperature affect kidney stone formation. As you can see, Sudan, number 15 in this, and Saudi Arabia and South America. With India, they are forming a lot of kidney stones, and also in Australia. So, definitions. When we talk about urolithiasis, urolithiasis is the presence of caliculi in the urinary tract. It can be within the kidney, and in that case, we call it nephrolithiasis. It can be in the bladder, and in that case, we call it urethrolethiasis and cystolithiasis. Nephrocalcinosis is a condition that's similar to formation of kidney stones, but it's a condition that precedes kidney stone development, and it consists of microscopic deposition of calcium throughout the renal parenchyma, usually in the medullary region. As you can see here, this is medullary nephrocalcinosis and this is cortical nephrocalcinosis. And these are stones in different areas. This is a kidney stone, bladder stone, ultrasound, and urethral stone. So either you have urolithiasis or nephrocalcinosis. And in general, nephrocalcinosis, when you see it, you can also try to investigate why this child has nephrocalcinosis. The pathophysiology of kidney stones has been described by the Randall hypothesis. And in general, Randall hypothesis hypothesized that actually there is something called stone inhibitors and stone promoters within the urine that is being formed in the kidney. And when we do have discrepancy between the stone inhibitors and the stone promoter at a certain pH level, the salts of the different salts will start to nucleate, and then they will grow, and then they will aggregate, and then they will cause nephrolithiasis. Central to this is the supersaturation of the urine with the crystals of the specific salts. Once we have supersaturation, we will have nucleation, growth, and aggregation. Randall described that the urinary inhibitors like citrate, magnesium, pyrophosphate, and uromodulin, whether it has been affected by GI problem or it has been affected by renal problem, once it is decreased compared to urinary promoters, there will be formation of what's known as Randall plaque. And the Randall plaque is the first salt that can aggregate together, and they will form what's known as nidus. And once this nidus has been formed in the kidney tubules or in the kidney medulla, then the stone will be formed over time. And in this theory, the main promoters of stone are calcium, oxalate, phosphate, urate, and cysteine. And so Randall hypothesis has been proven on the kidney when you go with ureteroscope. It has been seen that if you did a ureteroscopy in the pelvis in patients who have kidney stones, this is the picture you will see. The ureteroscope can reach the renal pelvis, and then it can look at the calyces, minor and major calyces, and the papilla, whether it is in the upper lobe, mid lobe, or lower lobe. If you see here, this description, this is a normal where papilla and minor calyces meet together to form major calyces. And this is one of the, what we call here is the formation of kidney stones. This is a normal kidney. This is a normal papilla. If you see here, this is the start of deposition of the nidus. And then if you went here and over time, you will find that the stone has been seen and started actually to form within the papilla of the kidney. The kidney stones don't form in the tubules directly. They start from the interstitium and then into subcutaneously here, and then they will form a punch inside the tubules. And so Randall plaque is forming the basis of hypothesis for kidney stone formation. There is other hypotheses like the free radical hypothesis and other ones, but these are just like for your interest if you would like to read about. Clinical presentation. When we come to the presentation of kidney stones, as you can see, urolithiasis can present with abdominal pain, vomiting, malaise. Most importantly is renal colic. You can have renal colic depending on where is exactly the location of the stone. If the stone location is within the kidney itself, you will have costovertebral pain. If it is in the ureter, you will have flank loin pain. And if it is going down deep into the ureter, you will have into vesico-ureteric junction stone, you will have growing pain that can extend to scrotum in male, and it extends to the labia in the female and the inner thigh. Urinary tract obstruction, dysuria, frequency, hematuria, fever, and UTI, sterile leukocyturia, or it can be also accidental finding in ultrasound, X-ray, CT, MRI, abdomen. Anuria is a presentation that can sometimes come with the finding of bilateral obstructive renal stones. The real presentation of urolithiasis is enuresis and penile edema. And usually this will be present if you have a urinary bladder stone or if you have urethral stone. On the other hand, nephrocalcinosis, it can present with the same features, but usually nephrocalcinosis is asymptomatic condition. They can present, you can find RBCs in the urine, hematuria. You can find sometimes failure to thrive, and it depends on what is exactly the diagnosis associated with the nephrocalcinosis. In younger children, they present with irritability, vomiting, hematuria, non-specific abdominal pain, failure to thrive, and UTI. And you might not find the typical presentation of kidney stones in older children and in adolescents also. Evaluation of children with urolithiasis start with a good history and physical examination, and they are indispensable part of what we call the assessment of children with kidney stones. We have risk factors for kidney stone that can start early, and that's why perinatal history, antenatal, natal, and postnatal history are very important. History of NICU admissions, diuretic use, polyhydramnios, they are all important. Patients who have congenital anomaly of the kidney and urinary tract, they are at risk of urolithiasis. Recurrent UTI, intestinal malabsorption, people who have bowel resection, Crohn's disease, and inflammatory bowel disease, cystic fibrosis. These people, they have normality in oxalate metabolism, and they might come with kidney stones. Immobilization, diabetes mellitus, and hypertension, although they are adult disease, still they are on the rise in obese adolescent children, and they might come coexistently. Medication is essential when you talk about kidney stones. Some antibiotic, anticonvulsants, diuretic, corticosteroid, chemotherapy, antacids, and protease inhibitors are putting patients at risk of kidney stones. And you can have some patients who are on long-term treatment for certain conditions, they can present with kidney stones. Dietary history is important. You need to talk about what is the patient habits when it comes to kidney stones. Some people might have kidney stones because of hypercalciuria, which is a condition that can be exacerbated by high salt intake and low water intake, and it has other causes, but mainly it is also diet related at some point. Use of vitamin C, D, herbal products also, ketogenic diets, this is also associated with kidney stones. Family history is very important, especially in children. You have to take family history about previous stone, relative with the stone, parents, and siblings. History of renal failure, kidney transplant, dialysis. These are very important to ask about. A special consideration in the social history need to be given to water supply, storage, and intake. As you know, some people who have purity of water supply in different countries are different. And so you can have kidney stones because you are drinking non-pure water. Occupation or daily life activities, blacksmith people, they are at risk of kidney stones. People who are working in hot weather, they are at risk. People who are working in bakeries, also they are at risk, and so on. Physical examination in children with urolithiasis is also important. You have to look at the growth of the child, and you have also to look if there is any dysmorphic features, and you have to look at rickets, whether it is coming from you have bone abnormalities. Lower urinary tract stages, spina bifida is also important, and also these need to be taken into consideration. In addition to this, a lot of inborn error of metabolism, at some point they can present with kidney stones. So you need to be vigilant in physical exam. Evaluation of urolithiasis after history and physical examination, you will go to do a biochemical analysis of the urine and also of the blood. And in this, you will start with the urine and you will do these tests simultaneously. You will start with the urine and do the pH, specific gravity, and basically the urine dipstick with the urine general. And don't forget to do the culture. 24-hour urine sample is also important, and usually it needs to be done in 2 consecutive times. Although 24-hour urine collection is difficult in children, but in patients with a kidney stone, it is important. So if you have a child who is like 5 years old and above, and he can collect the urine, it's better to do 24-hour urine collection. And we do it because we need to see the random concentration of different electrolytes like calcium, creatinine, phosphate, oxalate, urate, and so on. We will see later. Microscopy is an integral part of assessment of patients with urolithiasis, and you might find urine crystals. Regarding the blood, you will do different investigation, as you can see, including acid-base status and including renin aldosterone in case of like you would like to see about barter and oxalate and so on. This investigation might not be present in Sudan for sure. They are too costly for the patient, but you need to know that with the physical exam and history and simple targeted test, we will reach the diagnosis actually of kidney stones. So these are just as for your references. The evaluation of kidney stones also, it goes a little bit further, and in the third step, you will do calculation of solute and electrolyte urinary excretion profile, as we will see. You will do stone analysis, very important, either using infrared spectroscopy or X-ray diffraction. You will do genetic testing, and you will also do imaging, which is also part of evaluation. In the coming slides, we will be talking about these modalities. Urine excretion of metabolites is important. We need to know why this patient developed kidney stones. And when you are trying to look at the urinary excretion of metabolites, you need to remember what we talked about, the promoters and inhibitors. You need to look is the citrate concentration and magnesium is normal or they are disturbed. Hypocitraturia and hypomagnesemia, they are telling you that this patient is having something that formed the stone. On the other hand, if you look at the promoters of kidney stones, you need to look at, do we have hypercalciuria? Do we have hyperoxaluria? Do we have high sodium excretion? High urate? Urate is, we ask what is urate. Anyone can say what is urate? Do you have any comments about urate, ya Safi, in the chat or in the Q? Yani?
No
Okay,
comment.
urate is, okay. Urate is actually is one of the ion of uric acid. Yes, it is one of the form of the deprotonated form of uric acid. And so we take a look at these promoters, including also cysteine. Okay, and when we are calculating, you can calculate by looking at if you have 24-hour urine collection, you will come here to what's known as timed all ages. Tamam? And if you have a random, like a spot urine, it can be measured by milligram or millimole. Okay, and so these are the age spectrum, and these are the reference value. And so we try to make an impression about how is this urine going of this child with the stone. Is he having hypercalciuria? Is he having hyperoxaluria? Is the cysteine excretion is so high? Or is he having like high uric acid? With citrate magnesium, and don't forget the urine pH. Very important to also look at the urine pH with the urine volume. So all these parameters together can give you a clue about what are you dealing with. The crystals in the urine, as you remember, we said that during the urine investigation, we send urine for crystals. The crystals in the urine is being tested by what's known as polarized microscopy, and it is part of stone investigation. Different crystals in the urine can tell you what are you dealing with. For example, if you have calcium oxalate monohydrate crystals, this is look like oval, as we will see. They are usually seen in primary hyperoxaluria, which is a genetic condition by causing a problem in the liver enzyme that metabolize the oxalate. It will be defective and it will cause kidney stones. You have also calcium oxalate dihydrate. You have uric acid stones. You have strovite cysteine and 2,8 dihydroxyadenine, which is responsible also for some form of adenine phosphoriboside transferase deficiency. It comes with kidney stones. And you can also have crystals of some medications like sulfa medications and acyclovir. We will take a look at these crystals. As you can see here, the appearance of these crystals has been drawn here. So we will be taking a look at them, and each crystal has a specific appearance that can help you know exactly what are you dealing with. So let us take a look at what is exactly the crystalluria can tell us about kidney stones. And as you can see, they are also related to acidic urine pH. You can see that uric acid stone, for example, can form in acidic pH. Calcium oxalate and calcium oxalate monohydrate, dihydrate, they are all in acidic pH. Interestingly, in the alkaline pH, you have the strovite stone, and also you have calcium phosphate stone. So this is an example of crystals, and these are crystals of monohydrate and dihydrate, and they are seen in generally in oxaluria, and they denote that the patient is have hypersecretion of oxalate, and the secretion of oxalate can be in some people. If you find the calcium oxalate monohydrate in these patients, you need to suspect that whether they have primary hyperoxaluria or no, because presence of calcium oxalate monohydrate highly suspicious for this condition. Calcium oxalate dihydrate or bihydrate can be also present, but it can be present in different disease situation, like enteric hyperoxaluria, for example, from bowel resection, from Crohn's or inflammatory bowel disease. And so this, the shape here is dumbbell shape, as you can see, or biconcave shape, and the shape of the dihydrate is envelope or pyramidal. Any suggestions about what is these crystals for? This one? Any suggestions? What could be these crystals?
You can write your comment, please, in the chat. There is one answer, oxalate.
Mm-hmm. Okay.
No answers.
No further. These are actually uric acid crystals. Okay. Let's take a look at these crystals. What do you think about this one?
في answers جات later دكتور محمد، يوريك وفي تريبل في
Yeah.
يوريك. الشباب
Yes.
ردوا مؤخرا.
Yes. Okay. So what about this one?
Some answers. 16.
Okay. Cysteine crystals No, they are not cystine crystals. The picture on the right side, here is urine microscopy, and these are leukocytes, the one in the yellow. So any suggestion what these crystals? They are coffin lid shape.
There is someone answer infection and one said
Yes,
phosphate.
yes, infection, and the most common stone that's come with infection and come with this shape of crystals is strovite stone. Okay, strovite stone, magnesium ammonium phosphate stone. It is called triple stone. And this one already someone talk about cystine. This is a cystine crystals, and as you can see here, it is hexagonal. Okay, it is very characteristic. If you see these crystals, you suspect what disease that caused the stone? Cystinuria, okay, which is the commonest tubular disorders that's present worldwide. Okay, of course, in adults and in pediatrics, maybe it is not the fairest one, but is also very common in causing the stone. And these are what's known as sulfadiazine crystals. These are drug related, and sulfadiazine can be used in patients with toxoplasmosis who have also ocular toxoplasmosis. Yeah, these are sulfa related, and they look like this in the urine. And so with the crystals investigation, or what's known as when you send the urine to diagnose stones, part of the sample of the stone go to what's known as morpho-constitutional stone analysis. And the morpho-constitutional stone analysis is a little bit advanced more than the crystal analysis. Okay, they actually look at the stone morphology, and they cut the stone and they look at the surface of the stone after cutting from inside. And according to the morpho-constitutional stone analysis, they can get a very important information about this stone and how it is formed and what constitute exactly the stone. Which kind of salt has been supersaturated in the urine, and they cause aggregation and formation of this stone. Okay, and as you can see, the morphology and the morpho-constitutional analysis, it has classification. You can have what's known as wewellite stone, and this is the mineral name. When you see the main component here, they are talking about the mineral name. Each mineral name corresponds to chemical name. So for example, wewellite here is actually corresponding to calcium oxalate stone, monohydrate. Widylite is corresponding to calcium oxalate dihydrate. Okay, uric acid stone, as you can see. Carbamazepine is related to calcium phosphate stone. Brochite stone also is related to calcium phosphate stone. And so each stone analysis, they can give you a hint about what diagnosis you are dealing with, or what is the most likely diagnosis. Okay, and so strovite stone is being seen in UTI caused by urease splitting organism. Cystine stone, if you find cystine stone in the urine, as you can see type 5 here, this is unambiguously diagnosed the condition of cystinuria. Okay, and so on. The wewellite stone, which are the calcium oxalate monohydrate, are related to primary hyperoxaluria, enteric hyperoxaluria, okay, sometimes dietary, and sometimes it can be seen in cases of urinary stasis, okay. The wewellite, which are calcium dihydrate, they are related to hypercalciuria, and they can be associated with conditions that cause hypercalciuria, whether the hypercalciuria is absorptive, resorptive, or renal. And so these are the shapes of the stone. What you are seeing here, this is a typical calcium oxalate monohydrate stone, okay? And if you cut the surface of this stone, this is how it looks from inside. Okay. On the other hand, the calcium oxalate dihydrate, these are the white ones. And if you cut it also, you can see this is how from inside. And so if you look at these stones, these are a stone that form in the urinary tract. They are hard. They have different characteristics, and there's a lot of testing that goes in this area, and to see exactly which stone can be cut it, and the physiochemical characteristic of each stone and the solubility also of each stone. These are example of brochite stone, which are calcium phosphate stone. They are very hard. They cannot be treated with a laser or shockwave lithotripsy. They have to be actually extracted. Okay. And these are cystine stone. Okay. They are present in patients with cystinosis. This one is the uric acid stone, and this is how it looks from inside. Okay. And these are strovite stone, magnesium ammonium phosphate hexahydrate stone. And as you can see, the strovite stone are the commonest cause of staghorn stone. If you find it, look, it takes the shape of the calyces of the kidneys. When you come to the investigation of the kidney stones, you have the radiologic imaging, and we usually start with ultrasonography, and it has sensitivity of 94%, sensitivity of 90%, specificity of 94%. They are good in detecting kidney stones and upper urethral stone, but the ultrasound will not detect lower uretary stone. And so for this reason, if you have ultrasonography with the patient who is still have signs and symptoms of kidney stone, and you are still suspecting it, it's better to go for non-contrast computed tomography. Okay. In our setting and in general setting, the plain abdominal X-ray for the abdomen can detect for you it's a stone. But in this case, the stone need to be opaque. Okay. Opaque stone like calcium oxalate phosphate and like triple strovite stone, they can be detected on abdominal plane X-ray. Okay. Uric acid stone, they are translucent. They cannot be detected by plain X-ray. And also cystine and cystinuria, they are poorly opaque. They might not be visualized. So if you come to the imaging, you can do plain abdominal ultrasound followed by, plain abdominal X-ray followed by kidney ultrasound for the ureter and bladder. And then after that, if you diagnose the stone and if you see it, okay. If you didn't see it, you can go further to ask for CT for the CT KUB. So up to here, how children with stone disease, they are different from adults. We have talked about the pathology. We have talked about the investigation and the approach to children with kidney stones. And now the main question is, the stone disease, is it similar to the adult or they are different in case of children? Compared to adults, a predisposing cause for stone formation is found in about 2/3 of children, and it includes metabolic, anatomic, and infectious factors, alone or in combination. About 50% of children under 10 years of age with stone disease have an underlying metabolic condition caused by a renal, enteric, or endocrinological abnormality. The chance of finding a metabolic risk factor is higher in infants, and especially patients who have positive family history on consanguinity, and those with recurrent kidney stones. The risk of CKD and end-stage kidney disease is doubled in patients with recurrent stone former compared to non-stone formers. Thus, in children, the primary goal of a stone workup is to identify the hyperexcretion of specific solutes that are likely to drive the stone formation, and try to characterize the urinary content of inhibitors versus the promoters of kidney stones. Okay, and then we try to come up with diagnosis. And so children who have kidney stones, we need to diagnose them. You cannot just say this stone happened coincidentally, or this stone will not come back. Okay, you have to investigate what caused the stone, and you have to have a findings of from the history and your physical exam and your investigation why this patient developed stone. You might come up with a metabolic abnormality or infectious factor or anatomic problem, or this in combination in 2/3 of cases. And so the take-home message from today's presentation is presentation of urolithiasis in children is heterogeneous and need investigation for the underlying cause of the stone. And urolithiasis in children have recurrence risk and need to prevent formation of future kidney stones. And the recurrence risk of kidney stones is different depending on what condition we are dealing with or what disease caused the stone. Genetic testing. Can genetic testing help in urolithiasis in children? To answer these questions, you need to look at the studies. The studies who have done genetic testing, what's known as high output mutation analysis of 30 known genes for nephrolithiasis and nephrocalcinosis in 268 patients, they identified 21% in pediatric patients who are less than 18 years who are positive for genetic or what is known as monogenic causes of nephrocalcinosis and nephrolithiasis. Okay, and not only in children, they also identified 11% in adults more than 18 years. And the diseases that is associated with monogenic inheritance and kidney stones in adults and pediatric patients, they range from cystinuria, renal tubular acidosis, uh, familial hypomagnesemia and hypercalciuria, primary hyperoxaluria, and so on. And within these diseases, we'll see later each inheritance and how what is the mode of inheritance of each one. Also, Brown in his study, they study 143 patients, and 86% of them had nephrolithiasis and 14% had nephrocalcinosis. He identified that nephrocalcinosis and urolithiasis in 16.8%. In these cases, he identified a monogenic cause of kidney stone. And he also described that the recessive inheritance, they usually present early, while the dominant one, monogenic dominant abnormal mutation in certain genes, they can cause nephrocalcinosis and urolithiasis later on in life. And as you can see, the description here, OCRL, SL3A1, CYB24A1, these are genes for different diseases. OCRL1 like Lowy disease, CYB24A1, this one is related to vitamin D 24, 25 deficiency, ATP-V01 RTA, and so on. And so if you look at these two studies, you will know that the role of genetics cannot be underestimated. And actually, we can diagnose kidney stones based on genetic diagnosis. And so the question will be, when should I suspect a genetic cause in a child with nephrocalcinosis or urolithiasis? And again, you will go back to the history, early onset family history, related parents, consanguinity, multiple recurrent stone, okay? In your physical exam, you have to be careful about what are you looking for. Dysmorphic features, growth delay, developmental delay, ocular abnormalities, sensorineural hearing loss, bone disorders, and dental abnormalities, they can point to features of hereditary or monogenic cause for the kidney stones, along with also rickets. In the renal imaging, early onset medullary nephrocalcinosis with recurrent urolithiasis, they can point you towards suspicion of genetic disorders. In laboratory assessment, certain conditions with monogenic inheritance, they can come with acidosis, alkalosis, Fanconi syndrome. They can also come with impaired kidney function at very early age. Particular stone composition or crystalluria. as we discussed earlier. If you find monohydrate calcium oxalate, we will write cysteine, dihydroxyadenine, uric acid, and xanthine crystals. This diagnosis is unambiguous. You have reached the diagnosis. Okay, so in patients who have cysteine, the diagnosis is cystinuria, and so on. And so the crystalluria and stone analysis and stone composition and the morpho constitutional analysis, they will help you in exactly trying to identify what are you dealing with. And they are also part of the suspicion of monogenic cause. If you come and look at the monogenic causes, as you can see there is a lot of monogenic causes. Bartter syndrome, for example, it can come with nephrocalcinosis and also alkalosis, okay? And also it can come with polyhydramnios during the neonatal period. And it can come also with polyuria, okay? And so you can suspect Bartter in cases if you have polyuria with alkalosis, craving for salts, they have a very high, sometimes craving for salts, and so on. Patients who have like Dent and Lewy disease, these patients come with Fanconi syndrome, okay? And so you need to look also at glycosuria to see amino aciduria and so on in the urine, okay? Patient with hereditary hypophosphatemic rickets, they can come up with kidney stones, okay? And these also need to be taken into consideration. And as you can see, there is multiple genes that can cause HHR. There are multiple genes that can cause Bartter or Dent disease, okay? Autosomal dominant hypocalcemic or with hypercalciuria is also an interesting condition. It affects the calcium sensing receptor gene. And so you might be dealing with a metabolic or endocrinological problem. Familial hypomagnesemia with hypercalciuria and nephrocalcinosis, abbreviated as FHHN, it has two types. CLDN is abbreviated for Claudin 16 and Claudin 19, which they are tight junctions present in the kidney tubules. And if you have abnormality in these tight junctions, you will have abnormality in the handling of magnesium and also with calcium, and so precipitation of calcium salts. And they are autosomal recessive. To differentiate between them, the ocular abnormalities that is present in Claudin 19, this will point to monogenic cause, okay? Infantile hypercalcemia also has been also associated CYP24A1, okay, and SL3 4A autosomal recessive. And these also come with hypercalcemia. And so you have to also look at cystinosis. Don't confuse condition of nephropathic cystinosis with cystinuria. They are different, okay? And so nephropathic cystinosis is accumulation of cystine within the lysosome, okay? And it is actually pathology is something in carrier called cystinosine, which is abbreviated as CTNS, okay? And so if you have a problem in the gene of CTNS, which is the carrier of cystine inside the lysosome, you will end up with cystinosis, okay? It is a multisystem disease, okay? Also, you have primary hyperoxaluria, which can affect the liver. And as we say, there is type 1, type 2, and type 3. It's also a multisystem disease. It can affect the bone marrow, can come with severe anemia, bone deformity, kidney stone, end-stage kidney disease, and hyperexcretion of oxalate in the urine. And these patients who have type 1 AGXT hyperoxaluria, these people, they can present in the early ages. They can present with nephrocalcinosis since the early age. And that's why you need to be vigilant that patients who have nephrocalcinosis not to be missed, okay? Some form, they can be treated with pyridoxine if you have partial deficiency. And recently, they have come up with treatment which is called lomaziran. And this lomaziran is very expensive treatment, but it can treat the hyperoxaluria. Distal RTA, renal tubular acidosis, as we said, cystinuria, hyperuricosuria. In the uric acid, you have Leishman syndrome, and you have also renal hypouricemia. They can also affect the uric acid metabolism. You have also xanthinuria and so on. And so you have a lot of conditions that can come up with kidney stones. We come to treatment of urolithiasis. In the treatment of urolithiasis, you have the treatment medical management of the acute painful episodes, prevention of the recurrence, and urological interventions. So we can divide the treatment into these three. Management of the acute episodes consists of, if you have, for example, ureteric stone, patient coming with severe pain, okay, and or renal colic, you can, first step is to relieve the pain. And you can use, in this case, paracetamol with non-steroidal anti-inflammatory drug, and be careful to make sure that the renal profile is normal. If you have elevated renal profile, you cannot use the non-steroidal anti-inflammatory drug because they will exacerbate the decrease in the GFR. You have to also manage the UTI. If you manage the UTI, most of the kidney stones, when they come up with stasis and obstruction, you have to make sure that you don't have features of UTI in your urine analysis and also urine culture. Facilitating passage of stone. You give good hydration, 1.5 to 2 times in normal, hoping that the hydration will try to make a good non-reduced or saturated urine, and it will dilute the urine, and hopefully the patient can push up the stone and to get rid of the accumulated salts that's present in the urinary system. Medical expulsion therapy, and this is using a treatment called tamoxifen. This is actually has been tested, and it is useful also in children. Okay, it can cause side effects of hypotension sometimes, so you need to be careful. The dose is between 0.2 to 0.4 milligram if it is less than 4 years of age, and above that you can use 0.5 milligram. Oral chemolysis. Oral chemolysis, it has been tested in patients with uric acid stone. Basically, you give alkaline therapy, as you will see later. If you give alkalinizing therapy, the uric acid stone can dissolve, and usually they dissolve if they are 5 millimeter or less. And you try to create a urine pH of 7 to 7.2, not more than that, because if you create a very high alkaline urine pH, you might end up with calcium phosphate stone. And then you consider referral to pediatric urology. Okay. Some people also worth mentioning, they use pethidine for pain in patients with kidney stones. Usually, pethidine can cause nausea and vomiting. And so they are advising for, if you have severe enough, you can go for opioids or narcotics like morphine, okay, with all the difficulties. So immediate urologic intervention for decompression. And this is when exactly the urology should intervene urgently. So if you are in an emergency department, okay, and you have a patient who is coming with a kidney stone, if he has severe pain in spite of adequate analgesia, okay, you need to consult the urologist to come as emergency, okay? And it signifies if you have severe pain despite analgesia, you might be dealing with pelviureteric junction or vesicureteric junction stone, or stone more than 5 millimeter, which is unable to pass spontaneously. If you have a patient with urosepsis in an obstructed system, these patients also need to be seen urgently, and they need to be stabilized with IV antibiotics, and they are at risk of severe septic shock. Anuria with complete obstruction, acute kidney injury secondary to partial obstruction by a stone, solitary kidney. If you have solitary kidney with a stone, please call the urologist, because this is a life-saving procedure. He has to deal with this stone. Okay, bilateral ureteric obstruction, significant ipsilateral hydronephrosis. So if you have these features, try to consult the urologist urgently. They need to decompress the system, and then after that, they need to deal with the stone, okay? Prevention of recurrence. As we said that some of the stone, they can recur. And this is very important. When you do your urine analysis and you do your calculation in the urine, this is exactly why we are doing these investigations. If you have hypercalciuria, you need to make a dietary plan and a pharmacologic plan. Please do not make only pharmacologic plan. You have to take a look at the dietary plan, because this is what the patient is going to get used to it, okay, in his daily life. If he didn't change his dietary, the stone might persist and it might recur actually, okay? And so in all the dietary plans, as you can see, high fluid intake is number one. Whenever you have hypercalciuria, hypocitraturia, oxaluria, whatever it is, okay, you have to make this patient take water in large amounts than usual, and he need to be aware of his fluid intake, okay? So for example, when you ask the parents, how much is your child drinking? Usually they don't know. Some of them they will say, actually, he doesn't drink a lot. And some of them they will say, he rarely drink water. Okay. You need to understand that fluid intake is very important. Okay. And the rationale of fluid intake is basically you are trying to dilute any supersaturation that's present within the urinary system. Okay. Restriction of sodium in cases of hypercalciuria, okay, high potassium and high magnesium diet also has been tested, and they found to have effect as inhibitors of stone formation, okay. And so also you need to be careful in cases of hypercalciuria to have high fiber diet and low oxalate diet, okay. Regarding the calcium intake, in patients who have hypercalciuria, you need to be aware that we are not stopping the calcium. Okay, if you stop the calcium, the patient will end up with oxaluria. Okay, why? Because the calcium is needed in the gastrointestinal tract to bind with the oxalate, and it is also an important regulator of oxalate secretion in the stool within the GI tract. And so patients who have deficient calcium diet, they can end up with secondary hyperoxaluria. And so please, if you have someone with hypercalciuria, do not say for them, decrease your calcium intake or make it zero, okay? Usually, those people, they are advised to drink 600 milligram of calcium daily. That's it. So it is not a complete cessation of calcium, okay? When you come to the pharmacologic management and alkalinizing treatment, you have the hydrochlorothiazide. It can affect the calcium, it can reduce the hypercalciuria, and also potassium citrate. Okay, so these can be given in patients with hypercalciuria. Patients who have hypocitraturia, which is associated with stone, usually those patients can have uric acid stone, and also they can have calcium phosphate stone, which is associated with hypocitraturia, and it is usually seen in renal tubular acidosis. So these patients, they need also some form of citrate, and they can get citrate from fruit and vegetables and also from lemon, okay? And high fluid intake also is important, okay? When you talk about the animal and protein intake, it has been tested that high protein intake can precipitate hypocitraturia and can precipitate hypercalciuria. And in patients who have a high protein diet, the commonest stone that has been found is uric acid stone. Okay, and so the combination of uric acid from protein diet or animal protein diet, hypercalciuria and hypocitraturia can lead to formation of kidney stones. Okay, and so the recommendation is to keep the patient on the daily allowance of protein intake. When you come to hyperoxaluria, patients who have hyperoxaluria, the fluid plan in patients with hyperoxaluria is to drink more than 3 liters per meter square. Okay, and hyperoxaluria is a very difficult disease. Okay, it is multisystem disease. The oxalate can enter into different tissues. It can cause basically dysfunction in every part of the body. Okay, the patient will come with oxalate that is deposited in the bone marrow. And this oxalate that deposits in the bone marrow, it can it can consume all the bone marrow, leading to severe anemia. And no matter what you do, the oxalate will continue to be deposited in the bone marrow. And every time the oxalate decrease in the serum, okay, and try to reach a lower level, some of the oxalate will go out of the bone marrow and it will saturate the serum. And so patients who have hyperoxaluria, it needs another session to talk about hyperoxaluria. Those patients have a very high morbidity disease, okay? And it needs to be really careful when you try to treat them. And basically, a lot of nephrologists, they know that no matter what you did, the patient actually will end up with end-stage kidney disease if not treated early, and if not started treatment of lomaziran, the one that we talked about, okay? The treatment of hyperoxaluria, the disease that I talk about is the primary hyperoxaluria, which is deficiency of the liver enzyme AGXT. And the other oxaluria, the enteric one, okay, you can try to manage by potassium citrate. Sometimes you can give also magnesium, pyridoxine. Sometimes if you have partial deficiency of the enzyme, it might be corrected by pyridoxine. Neutral phosphatase or neutral phosphate also can be given. It will help with the oxalate absorption. And so these patients, they need to have also avoid excessive vitamin C and avoid low-fat diet. And all this because oxalate can be absorbed from the intestinal tract, okay? Hyperuricosuriya, this patient, as we said, restricts the sodium, avoid the dietary allowance for animal protein is the regular one, not to increase high fluid intake. And also you can use potassium citrate and allopurinol. Allopurinol is also can be used in hyperuricosuriya. Cystinuria, those patients with cystinuria, they have problem with the cysteine and handling of the cysteine within the kidneys. They also can benefit from high fluid intake, potassium citrate. They have some medication that has been tested in cystinuria is alpha mercapto propenyl glycine, Thiola, and also D-penicillamine and captopril. This has also been tested in cystinuria. And so from this slide, you can see that we are using alkalinizing agents. And the alkalinizing agents usually is potassium citrate, okay? And people who have worked in Sudan and they manage patients who have renal tubular acidosis like this, these patients, they have what's known as, you have polycitra 1, polycitra K, or you have sodium, potassium bicarb, polycitra 1 and polycitra K, and you have also salt solution, which contain only sodium and bicarb. So we can discuss this one later on in the discussion. But in general, the alkalinization treatment, if you start it, you need to make sure that your pH in the urine doesn't go above 7.2, okay? And in case of cystinuria, if you diagnose cystinuria, you can accept urine pH up to 8, okay? Otherwise, it's preferably to keep the urine pH between 7 to 7.2, okay? Hoping that further alkalinization might cause calcium phosphate stone. Okay, I think this is the last slide, and this one is talking about the surgical management of pediatric nephrolithiasis, okay? This surgical management of pediatric nephrolithiasis, it consists of either we do, what do the urology do for the stone? They either do as well, which is extracorporeal shockwave lithotripsy, or they do what's known as ureteroscopy. They go through the ureter, they go through the urethra, into the bladder, into the ureter, and then they try to handle the stone, okay? And this is called retrograde intrarenal surgery, RIS, okay? Or they come from percutaneous nephrolithotomy. And percutaneous nephrolithotomy is basically you come from the costophrenic angle, okay? You try to identify with the kidney ultrasound or with the probe inside the ureter, you try to identify the calyces, and then you go in, okay, with the needle, and then you look at the calyces, and then you open the calyces, and then you take out the stone. Okay, and so these also need expertise. Okay, recently laparoscopic and robotic surgery has been also uh, like coming to the place of the urology, and they are using it for minimally invasive surgery because it doesn't cause more complications or serious complications like the hemorrhage and infection and so on. So, so this is basically the last slide of my presentation. The algorithm for kidney stones. So if you have patients with the kidney stones, this is a suggested algorithm. Okay, either you have symptoms and signs of urinary stone, you do your history or physical exam, you do the imaging, your urine analysis, urine culture, and then you see exactly what are you dealing with. If you have no stone identified, but the history is suggestive, you will complete your investigation, the one that we talked about, blood and urine. Okay, you will advise the patient to have high fluid intake, okay, and reduce the sodium intake. Okay, and then you try to see what are you dealing with in the urine. Okay, if your stone is passed and recovered, and this is the best scenario actually, you ask the family to bring the stone. That's why patients who have kidney stones, very important recommendation is to look at the patient urine. If they find any stone or any deposit, they need to bring it. Okay? You do the stone analysis, and from the stone analysis, you identify what are you dealing with, either cysteine, strovite, calcium oxalate, calcium phosphate, or uric acid stone. Okay? And then you further start your treatment based on this identification. Okay? The recurrence treatment and the management. Okay? And you can also, from there, you can send for genetics and identify the pathology. Okay? If the stone analysis didn't diagnose the patient. Stone identified in the urinary tract on the kidney ultrasound, for example. In this case, you will do your urology consultation. They will do their management. Okay, either they said for you, we will do as well, or they will say for you, we'll do surgical removal or no intervention. Okay, once the urology, they did the as well or they did the surgical removal, you need to take the stone and send it for analysis. That's why the contribution between urology and nephrology is very important in these cases. Okay, and so patient with the stone, you do not say for the family it's okay, and it doesn't need follow up. He will need follow up. He will need further investigation, and actually, this patient will need follow up with pediatric nephrology and pediatric urology. This was my last slide, and thank you for your patience and listening. Um,
Thank you so much, Dr. Mohamed Karar, for this nice, informative, and enjoyable talk about urolithiasis. For the participant, I think we have around 160. We are interested to know who's from Sudan and who's from UK, who's from Qatar, and so on. Please, you can write in the chat, and don't forget to fill the feedback form, please. And I will give the chance for Dr. Alam first to comment, and then Dr. Mahjoub, then Dr. Hatim for Q&A, and Prof. Karim and Prof. Sat if they have comment. تفضل دكتورة نهلة.
Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Thank you for this excellent and informative talk, Dr. Mohammed, about kidney stone. I really enjoyed it and found very educational session. Yes, in Sudan, we have a lot of cases of renal stone. We do 2 studies. One, we search about risk factor for UTI in children in Khartoum state. That study done in 2019 included 136 child. Kidney stone represented 9.5%. ومmainly source of this child or his living area of source of water unhygienic. This is water, when analyzed, it is found full of salt and minerals, and created stone ended with UTI. This total of child presented about 11.8% living in that area, which is serious and need to be taken after Sudan settled to be search about the water and source of water, at least to be safe for drinking. And another study done about etiology of chronic kidney disease, etiology and outcome. This is second study done 2006 up to 2016. Participant about 360 child in this study. We found the one story presented as cause of CKD about 7.7%, which is high incidence. Also, we do a collaborative between us and Diabetes Center to Dr. Asmahan for analysis of stone, and said a lot of sample about more than 25 patients as workup before kidney transplants. Patient ultrasound repeats there is renal stone, but unfortunately we lost our report from Dr. Asmahan regarding this child sent for genetic study. And Koreas remember one of our that patient whose name Mohamed Karar. That child has hyperoxaluria, ended with liver and kidney transplant in India. This child diagnosed at Noor Center, Sobe University Hospital, and ended with liver and kidney transplant in India, and successful. And now I think he's postgraduate from university. Thank you.
شكرا دكتورة نهلة. دكتور ياسر محجوب.
Assalamu alaikum. Thank you, Muhammad Zain, for interesting talk and comprehensive talk. والله. Thank you very much. يعني استفدنا كثير والله. طبعا في السودان the handover of the renal stone by the urologist, يعني adult urologist, يعني up to 2018 when Dr. Aziza يعني come back, it is a pediatric urologist. But the handover usually by the adult, and as Dr. Nahla said, all the patients with renal stone will come late to renal unit or to the nephrologist or pediatric nephrologist. Muhammad Abdul Rahim reported إنه 6.5% of acute kidney injury is caused by the renal stone. And Nahla Allama, Dr. Tijan also reported end-stage renal disease causing by renal stone is 7.5, I think, percent. So we'll come late to the pediatric nephrologist. And the common component of the stone in the Sudan is the calcium oxalate. And this is common. I think it is 50%. Here reported by someone radiologist in Sudan University. The other things, كان main the children presented from the Western Sudan. As you know, إنه هم كامل main أو كامل heaters. The main nutritional is camel milk with rich by the calcium. فكان معظم البيشن اللي بيجوا من الويستر من الويسترن السودان. الشيء الثاني كان نحن بس deal with the genetic types. دائما الستون formation from the renal due to genetic أو due to metabolic زي ال RTA or genetic type زي الهايبروكساليوريا. فدي كان deal with him. فعلا كنا بنرسل الجينيتيك with endocrine دكتورة سلوى نسمهان نشكرهم. diagnose a lot of patient prepare for transplant and with renal stone with unknown etiology. فكانت تخيلي في زي 3 patient كانوا family with familiar hypermagnesemia, hypercalciuria, and there is 2 patients with primary hyperoxaluria. يعني دي كلها الستون. لكن طبعا هو يعني الستون is interesting talk was a lot of talk about it but is deal in السودان. في فكرة كانت يتعمل combine clinic with دكتورة عزيزة لكن ما توفقنا فيها يعني. الشيء الثاني كان الانفستيجيشن يعني is very difficult. يعني حتى اليورين اناليسيس sometime يعني ما بديك اي كلو، بدوك يعني كريستال فورميشن، يعني ما كان في كلو يعني كلير انفستيجيشن او كان في ديل ويز انفستيجيشن. ثانك يو فيري ماتش.
شكرا
عبد
دكتور.
العزيز، أنا شايف دكتورة غادة عثمان رافع يدها في دكتورة غادة is one of our teachers and she is working currently in Haile. فإذا ممكن تديها فرصة.
تفضل دكتور غادة.
دكتورة غادة, you can open your mic.
مرحب، السلام عليكم.
عليكم السلام.
أهلين دكتور محمد. يعني thank you very much for this really fantastic talk about renal stones, one of the complicated topic really. I'm very proud of you دكتور محمد, as usual يعني fantastic talk really. وفرصة سعيدة سمعنا دكتورة نهلة ودكتور ياسر وكل الكوليكس. Nice talk really. بس عندي one question لك دكتور محمد. For patients with hyperoxaluria in whom you will start thiazide, do you need to follow them with renal calcium creatinine ratio for adjustment of the doses, or you don't practice this? Thank you.
Usually when we try to do the urine, most of them they will come late stage.
Yes.
They don't even have this one. But if they come early, yes, we do calcium creatinine ratio. We do the full workup of solutes and the random urine. And we have currently like 2 patients or 3 patients who have primary hyperoxaluria discovered because of they have early nephrocalcinosis. And after we did the urine oxalate for like 3 consecutive time, the urine oxalate creatinine came to be high. And so we sent for genetics, and then after that it came positive, unfortunately. And they started on Lomaziran. This was the practice. But usually for treatment, if we diagnose early, we go directly for B6 and for Lomaziran. If we didn't diagnose early, they usually come with chronic kidney disease, and at that time the advice is we don't dig deep on the urine calcium creatinine ratio, because already we have a form of CKD, usually stage 5.
Okay, thank you.
You're welcome دكتور غادة, وتحياتنا من هنا إن شاء الله.
طيب شكرا جزيلا دكتور غادة. ودكتور حاتم, please, there is 2 questions, one from Dr. Umayma. Go ahead.
We have 2 questions. The first question is from Mohamed. Thank you, Dr. Mohamed, for wonderful presentation. My question is that in case of malignancies in which we do alkalinization, is this or urine pH reach more than 7.2, so can risk for the red stone, or because of short period there is no risk of that? Thank you. The other question is from
خليه يجاوب على السؤال بعد السؤال الثاني دكتور حاتم.
Okay, for this question, if you have patient with malignancy and you have like high uric acid or hyperuricemia, in this case, yes, you need to be careful not to get the urine pH high, because you will have calcium phosphate stone with the uric stone. Okay, and these are the commonest stone in patients with hyperuricemia. And the uric acid stone can precipitate in alkaline, in acidic media actually, but the calcium phosphate stone, they can they can precipitate in alkaline media. Okay, so the risk will be for this patient, you will be trying to deal with him as a uric acid stone patient who has malignancy, who had hyperuricemia. Okay, in this case, you can start with your management of alkalinizing agent, potassium citrate. You measure the pH, you make sure that the pH doesn't go above the 7.2 or 7.3 maximum. Above that, you risk the precipitation of calcium phosphate stone. The calcium phosphate stone in patients with malignancy usually also related to the hypercalciuria that can be associated with these conditions.
طيب the other question is from Faiza Muhammad. Thank you for this useful presentation. What about herbal medication like in Sudan? There is a lot of herbal using treatment of diseases. The other question is what is the dose of potassium citrate? And third question, what about use of next management?
Okay, thank you, Dr. Faiza, for this question. There is a lot of herbal medicine that is being used in Sudan for management of stone. And actually, there is one of the interesting reviews. It has been done by Dr. Fadl Al-Mula, I think, and it has been published in one of the journals of the University of Zaim Al-Azhari. They have medical journal. I cannot remember the name. They reported that there is a lot of herbal that has been used in Sudan, and in their explanation that still, although not tested formally, they might help in kidney stones. But the use of herbal medicine doesn't come without price. If you give herbal medicine without a formal testing, you can end up with end stage kidney disease. Okay, and you can damage the kidney. And so still we need more formal studies about this use of herbal substances. اوكي في ناس بيستخدموا يعني زي يعني عندهم different names different things في السودان، الحرجل والدسيسة وعندهم حاجات يعني في كل منطقة في ناس بيستعملوا أشياء مختلفة، لكن in general it is not formally tested and actually نحن we are not against it، لكن we are with more information about it. السيستماتيك ريفيو اللي هم سموها systematic review، لكن actually it was more of a scoping review. It was not a systematic review in a sense. They put a lethal level، كتبوا فيه الكونسنتريشن بتاع lethal level. فأنا I think إنه يعني الادفايس بتكون للبيرنتس إنهم يعني they can go with the regular recommendations of the diet. وإذا كان عندنا more formal information about this herbal substance we can come forward ونديهم معلومات أكتر عنها، لكن at the moment we cannot depend on it. What is the dose of potassium citrate? We can just refer back لل last table. You will find the dose. Usually it is 15 to 20 milliequivalent. Some people they use it like 3 times per day. وبرضه be careful إنه الستريت sometimes بيكون عنده risk of hypocalcemia وممكن يعمل يعني sometimes bleeding at some point يعني إذا استعملناه excessively. فبرضه يعني be careful إنه نكون مع الدوز ويو monitor اليورين PH. اليورينكس صراحة اليورينكس بيستعملوه ناس اليورولوجي كتير في السودان. And it has some role and it has been يعني قاعد يتباع هناك كتير and it is useful في acute episodes. فممكن نستخدم يورينكس for the acute episodes hoping that إنه it can help يعني at some point.
شكرا أستاذنا بروفيسور ساتي، تفضل.
السلام عليكم ورحمة الله. شكرا دكتور محمد زين على محاضرتك القيمة، وصراحة هي كانت مفصلة وويل أورجنايز وفهمتنا حاجات كثيرة يعني، أو راجعت لنا أشياء كثيرة جدا in detail. شكرا جزيلا و very useful يعني. عندي بعض يمكن الأسئلة والكومنتس البسيطة. uh, uh, children with biker are they more likely to get renal stones ولا ما لها علاقة بالحكاية؟ الكومنت الثانية the incidence of renal stones هل في فرق بين ال population أو children who depend on river water ولا water from the wells؟ يعني هل في difference في ال incidence أو في rate of getting أو risk of getting renal stones or not؟ الكومنت الثالثة أو السؤال الثالث في risk for more renal stones for children who are suffering from urinary dehydration. شكرا جزيلا.
شكرا دكتور ساتي. بالنسبة للسؤال الأول to best of my knowledge البايكا it has more relation للأيون deficiency anemia والنيورولوجيكال neurological symptoms أو CNS manifestations في البرين وكده. I didn't come across البايكا في الكidney stones. لكن maybe if we did some search maybe we can find something about about this. It is interesting. بالنسبة للسؤال الثاني اللي هو الووتر سورس. أنا to best of my knowledge الووتر تريتمنت إذا كانت من الويلز وكده يعني مياه الآبار عموما إذا كانت يعني ما هي contaminated أو كده ما فيها مشاكل. لكن sometimes you never know في some areas بيكون فيها الووتر contaminated زي ما قالت الدكتورة نهلة. يعني المياه الجوفية نفسها بتكون داخلة معاها موية تانية. ففي الحالات دي ممكن يعني البيشنت ممكن يجي due to drinking of contaminated وحتى من الويلز. هل في فرق بينهم وبين يعني موية النيل ومياه الآبار؟ أنا I cannot answer والله لأنه I don't have information about this. لكن برضو it is interesting to see يعني why people having يعني إذا كان في discrepancy زي دي و it is a public health issue يعني you need to involve وزارة الصحة مثلا في إنه what is going on، خصوصا إنه هسي حاليا مثلا في كوليرا منتشرة وكده. ففي حاجات كثيرة صراحة مع الووتر سبلاي والسيف ووتر وكده، جزء منها ستون لكن جزء منها حتى الأمراض الثانية الانفكشوس. السؤال الأخير اللي هو كان عن البلهارسيزيس. I don't know والله I didn't come across bilharziosis and kidney stones يعني whether it will cause or not.
دكتور ياسر
شكرا.
نهلا they have answer this question.
نسمع. ايوه، في البلهارسيزيس كان عندنا 2 كيس ريبورتد، هو ما بوبليشيت يعني، وهم كان بوزبل هارسيا يعني يورينري بالهارسيزيس. فكان عندهم ستون، فكان الاكسبلانيشن انه كان في زي ناروينج يعني من الشيستوسوما ديبوزيشن، عملت ناروينج وعملت يعني ستون. ده الاكسبلانيشن اللي لقيناه، يعني ما لقينا حاجه تانية. لكن في يعني بوبليش بيبرز خاصه من ايجيبت هي اسوشيتد مع الرينال ستون. شكرا. بعدين عندي كومنت على على العلاجات البلديه، يعني زي الصمغ العربي، البقدونس، يعني التوت البري. فهي دي معظمها اظنها يعني انكريز اليورين اوتبوت اكثر من انها هي يعني بتعمل فلاشنج. تخيل لي كده، يعني انا ما لقيت ريليشن بين الستو، يعني هي يعني بريفنت الستون اكثر من انها هي انكريز الانتيك الفلويد انتيك وانكريز اليورين اوتبوت. فتخيل لي كده، لكن ما لقيت حاجه تربط تاني. فشكرا جزيلا.
شكرا دكتور حاتم. there is question في الشات ممكن تشوفه على دكتورة أسماء تسأل سؤال.
عبد العزيز بس if you give me 1 minute. أنا I shared with you اللي هو الارتكل دي I came across اللي هو traditional remedies used in the treatment of urinary system and kidney disease in Sudan. اللي هو دكتور فضل المولى ودكتور عبد الباسط مريوت. يمكن يكون في جزء من أساتذتنا بيعرفوهم. فهم they did the systematic review. they go into a lot of يعني studies وكده, they have a lot of names. وحتى يعني مشوا forward وكتبوا الأسامي بتاعت النيمز حقت كله يعني كله substance, وقدروا يعملوا مثلا اللي هو في النهاية الريفيو بتاعتهم. it is more of a scoping review than a full systematic review. لكن you can refer to it. يعني ذاكرين الحرجل وذاكرين الكرسان وحتى الصمغ العربي اللي يتكلم عنه دكتور ياسر والتوت البري. يعني في حاجات كثيرة مكتوبة فيها وكاتبين يعني إنه there is يعني toxic effects إذا أخذت في دوز كبيرة أو في side effects ممكن يحصل منها. ف it is worth إنه الناس تشوف الأشياء دي, which is an area of research also as well. شكرا.
حاتم.
There is comment from Abdul Karim. The most important message delivered by Dr. Mohamed that the renal stone are not the disease itself. They are often a sign of underlying conditions that must be diagnosed and treated. Management should not stop at simply removing the stone and discharging the patient. Instead, every patient deserves a thorough evaluation to identify the underlying cause and implement the appropriate treatment. This comment, لكن I find it so.
طيب طبعا في a lot of thanks to you Dr. Mohamed for this nice presentation in the chat, and also I would like to thank all the participants for يعني علمونا انه من وين في a lot of من السودان ومن الامارات وفي شكرا على الريسبونس. و and I have question if there is time Dr. Mohamed. If you have patient with urolithiasis and the cause of it is genetic, and the patient ended with end-stage renal disease, do you go for renal transplant and it will succeed with this gene problem, or you need to do something else? Thank you.
أي patient if we are suspecting renal stone we have to know what is the disease. لأنه في some diseases they will recur after transplantation, especially إذا كنا بنتعامل مع metabolic disease. Okay. Primary hyperoxaluria بالذات is a special entity لأنهم they need combined liver and kidney transplant. in these cases إذا البيشنت undiagnosed وعنده high likely primary hyperoxaluria, نحن we need to know about this. لأنه if you transplanted the kidney before the liver, you need to continue this patient on treatment. Okay, and you need also to make sure the transplanted kidney not to fail. Yes, usually those patients they go into what's known as sequential transplant. اللي هما they transplant the liver first, and then after that they transplant the kidney, and this is the best scenario. Okay, isolated kidney transplantation in patients when primary hyperoxaluria is also tested, لكن you need to continue Lumaziran treatment, which is expensive treatment. Other undiagnosed condition with kidney stones, they can recur after transplantation. Thank you.
شكرا جزيلا دكتور محمد. I think we reached the end of this nice presentation. Thank you all. I hope you go for the feedback form and send it. We'll see you إن شاء الله. تفضل.
صافي بروف ساتي. أيوة تفضل يا بروف ساتي.
يا بروف.
معلش يا دكتور محمد، يعني عندي كويري يمكن نوت ذات بي. طبعا
أيوة تفضل.
as management advice you ask the patient to take a lot of fluids على أساس واحدة من المانجمنت. What
Yes.
does it make إنه الفلويدز دي تكون pure water ولا other juices ولا beverages وكده؟ لأنه بعض البيشنت بيفتكر إنه أنا لو أخدت يعني فلوس كثيرة just as beverages وكده ممكن تديك نفس الإفكت بتاع pure water. فهل في difference ولا do you think it is okay to take any sort of fluids? شكرا.
Yes, it does make a difference يا بروفسات. لأنه مثلا let me be clear معك. نحن we are seeing a lot of rise of junk food أو يعني drinks, soft drinks بصورة كبيرة جدا في الأطفال. يعني معظم الأطفال some areas they can drink بيبسي كولا وميريندا والحاجات دي والأشياء الغازية. كويس. في جزء من الأطفال برضو يعني بيعتمدوا في الديلي انتيك حقهم إنهم they don't actually drink any water. They depend most of the day على concentrated high sugar drinks، بالذات الشوجرز اللي ممكن تكون يعني اللي هو المصنعة اللي بتعتمد على السكر الصناعي اللي هي فريكتوز بيست. فدي it cause a lot of issues يعني في الكدني، وبتخلي السوبر ساتوريشن بتاع السوليوتس يعني يكون موجود. كويس. عشان كده الادفايس بتكون انه يعني تكتر من الخضروات ومن الفواكه على اساس انها source of magnesium and potassium، مع يعني اتليست لازم يكون بيشرب اتليست يعني 2/3 من الفلويد مينتننس حقته تكون شنو، تكون يعني ووتر، وسبيشالي في الهوت ويذر. كويس. يعني دي يعني دي الادفايس الجنرال اللي احنا بنديها للبيرنتس. كويس. وانه اذا مشى الحمام مثلا وشاف انه والله يا اخي التبول بتاعه very concentrated، that means انه هو he is not drinking enough water. He needs to go and drink more. كويس. فيعني دي الحاجات اللي احنا بنديها للجنرال يعني patients. في some patients بيكونوا polyuric by definition. ديل بيكون عندهم congenital anomaly of the kidney and urinary tract. وديل برضو they need to be aware انهم they have to يعني drink enough water.
شكرا يا دكتور محمد. Thank you.
شكرا يا بروف ساتي، وسعيدين انه انت موجود. و thank you for the discussion and comments.
شكرا.
شكرا جزيلا لكل الحضور الكريم، و remind you next week إن شاء الله will be قطر team. Thank you all وجزاكم الله خير. See you.